Hey everyone, and welcome to this week's community Q&A webinar. This is Catherine Small tuning in from the Healey Center at Mass General in Boston, and I'm joined by my colleague Allison Boulot, who's my patient navigation partner in crime. And we're also excited to share that we have a special guest speaker this week. Before I hand the mic over, I'm going to let people trickle in from the waiting room. But I do want to give everyone an update on some upcoming webinar opportunities. So if we move to the next slide. For those who attend regularly, I'm sure you know about our weekly webinar registration link, the ALS link, which is an email broadcast system. So if you sign up for that, that's a good way to get notifications about upcoming webinar opportunities and topics for the week. The next couple webinars on February 29th and March 7th are going to be our usual weekly Q&A webinar about the Healey ALS platform trial. The second Thursday of each month is a dedicated discussion about expanded access protocols. So on March 14th, we'll be joined by Dr. Jinsey Andrews from Columbia University to talk about EAPs. And this week, we are switching things up a bit. So we won't be talking about the Healey ALS platform trial. And instead, we're going to talk about some frequently asked questions pertaining to genetic considerations in ALS research. So if you have questions about the platform trial, we'll defer them till next week or the week after. Or we can follow up offline, but the discussion today will be about genetics. And so with that, if we head to the next slide, it is my honor and privilege to introduce you to Dr. Mark Garret, who works with us here at the Healey AMG Center at Mass General. And I'll hand it over to you, Dr. Garret, to give your presentation.
Perfect. Thank you so much for the invitation again to speak, Catherine and Allison, and to Dr. Paganoni as well. So I was going to talk mostly about genetics of ALS, kind of as it pertains to both people who have kind of genetic or familial forms of ALS, but also a little bit for kind of the broader population of ALS patients who have kind of sporadic disease. This is a really big topic, and so it's just kind of a brief overview, and then I'm happy to kind of take questions to really see what we can answer that may be more relevant to the individuals kind of who are joining us. Next slide. So one of the questions that I often receive in clinic visits with my patients is ALS inherited, and what is the risk to my family members? And so what we know generally is that about 15% of ALS is caused by changes in a single gene. And in those cases, we'll often refer to that as either genetic ALS or sometimes as familial ALS. Now, technically, familial ALS is defined when you have a patient who has ALS, and then there's a family history with one or multiple members of their family who've had ALS or related diseases that fall on the ALS spectrum, such as frontotemporal dementia. And overall, about 10% of ALS patients have this kind of family history consistent with a genetic etiology. What is notable, though, is that about 5% of patients who have seemingly sporadic ALS without any known family history do have causative genetic variants identified when genetic testing is performed. And this is one of the main reasons why, as time has gone on and genetic sequencing has gotten less expensive, that we really now routinely recommend testing every single patient with ALS for a causative genetic mutation, because otherwise we're missing about 5% of people. Next slide. So just to look at a little bit how the kind of most typical kind of causative ALS genetic mutations are inherited, almost all of these exhibit something called autosomal dominant inheritance. And so just for kind of a real brief review of genetics, every person has 2 copies of each gene in their body. And in the case of some of the most common genetic forms of ALS, we know that one abnormal copy of that gene is sufficient to cause ALS. So people usually have one abnormal copy and one normal copy. When somebody who has kind of a genetic form of ALS, we know that if they have children, there's basically a 50% risk of that parent, that affected parent, passing on that kind of abnormal or kind of disease-causing gene to any one of their children. And that difference doesn't depend at all on sex. So men can pass kind of the abnormal disease-causing version of the gene to female children and vice versa. Next slide. So for a long time, we had known about, that there were families that, multiple people developed ALS, and it was clearly consistent with some genetic or inherited etiology. But for a very long time, we really didn't have a good understanding of this. So that really started to change in 1993 with the discovery of the SOD1 gene as the first genetic cause of ALS, and that was done by kind of Dr. Bob Brown's group. And then really between around 2006 to 2011, we made a series of really big breakthroughs with kind of multiple different gene discoveries, with the most notable being kind of in that big circle with the C9orf72 gene mutation has been found to be the most common genetic cause of both ALS as well as another disease called frontotemporal dementia. In total, we now know of over 20 genes that are kind of definitively known to cause ALS. And there's about 50 that have been associated with the development of ALS, where maybe they're not clearly causative in most people, but there's an increased risk of developing ALS, potentially by a smaller amount in the people who have these. Next slide. So one of the really key concepts when we're kind of looking at and evaluating, whether genes, are directly caused by ALS, and when we counsel patients, who may be at genetic risk of ALS, is something called penetrance. And so this is really kind of what is the chance that if someone has a genetic mutation that we know is kind of associated with ALS, what is the chance that they end up developing the disease? And so this varies actually a lot. So the second most common genetic cause of ALS is a gene called SOD1 or SOD1. And on average in the United States, people who have SOD1 gene mutations, over the course of their lifetime, about 90% of them actually develop ALS, which is a really high number. The overall most common genetic cause of ALS is a mutation called C9orf72. And in this, the lifetime risk of developing ALS, while it's still very high, it is a little bit lower than for SOD1. The exact number has kind of been hard to pin down, but we think that somewhere between 50 to 90% of people develop who carry a disease-causing mutation in C9 will develop ALS or FTD over the course of their life. Oftentimes, however, this can come on very late in life, and so people who carry this gene mutation may sometimes never develop symptoms. They may die of other causes before they ever develop ALS or FTD. So SOD1 and C9orf72 are two examples of kind of gene mutations where most of the time there's kind of a stronger family history of ALS. Where this is often absent are kind of, if you're looking at the right side of the screen, essentially these genetic alterations that we refer to as risk alleles. Where basically there are kind of genetic changes in an individual that increase someone's risk of developing ALS to a much smaller degree than, say, C9 or SOD1. So one example of this is there's a kind of gene called ataxin-2, and a particular change in that gene gives somebody an increased risk of ALS that's about 3 to 4 times higher than what we see in the general population. And so since about 1 in 350 to 1 in 400 people may develop ALS over the course of their lifetime, we expect that the lifetime risk of someone who carries this ataxin-2 gene mutation is about 1%. So still the most likely thing for someone who has this is that they never develop ALS. Even kind of a smaller increased risk is what's called the UNC13A polymorphism. So this is kind of a change in a gene called UNC13A. And overall, this gives people about a 10% increased risk of developing ALS over the course of their life compared to the general population. So overall, what this really means is that, these risk alleles may be one of multiple factors that could contribute to somebody getting sporadic ALS. And it's kind of in this idea of, what's often referred to as a gene environment interaction, where you require multiple different factors to kind of result in someone developing ALS. And so it may be you have the UNC13A polymorphism, and someone had a history of concussions or military service or other things that may be associated with an increased risk of ALS. Next slide. So the reason why I bring this up and why I think it can be relevant to people even with sporadic ALS is I think it gets to this concept of precision medicine as a therapeutic tool. So I think many of our treatments may be more effective if we're really intervening in an individual at the root causes of disease. And so the goal for many therapies now is to try to tailor treatments to the underlying causes of disease in an individual. So that the furthest kind of develop of this, of these options is really for, this one of the genetic forms of ALS referred, called SOD1, as we said, where there's an antisense oligonucleotide called tofersen or Qalsody that was approved by the Food and Drug Administration in April of 2023. Um, so the way that medication works is it's actually something called an antisense oligonucleotide, where it's a small little piece of DNA that's designed to bind to a specific RNA sequence that's abnormal because of the underlying gene mutation. And it basically then leads to destruction of that piece of RNA and decreased levels of the protein, in this case, the SOD1 protein that causes the disease. What's been really exciting recently is actually companies are now trying to employ these same techniques to target people who may have sporadic disease. So there's now essentially these gene-targeted therapies that exist for ataxin-2 with a clinical trial that's ongoing internationally, and kind of earlier stage work that's not ongoing in the United States for proteins or the target proteins called stathmin-2 or STMN2. There's a small typo on my slides, as well as the UNC13A protein. Next slide. One of the things that I think is really exciting about, thinking of the genetics of ALS is really thinking about, could we use this knowledge to start treating people kind of earlier on in disease where I think it's more likely to be successful? I liken this to kind of potentially a house fire. It's easier to smother a fire and put it out if you intervene when it's just a small kitchen fire rather than when it's engulfed the whole house. Or when we're kind of potentially trying to treat people after the disease has been more progressed. Next slide, please. So one of the ways we've been doing this is really trying to identify who potentially could be at the highest risk of developing ALS. And we do this by kind of following the family members of people who have these genetic forms of ALS. So we have here at Mass General, we have a study called the DIALS study, and we kind of work in a partnership with several other kind of hospitals and neurologists at Washington University in St. Louis, as well as at Columbia University, where there's kind of the ALS families study. And basically in these studies, we essentially perform genetic testing in people genetically at risk for ALS prior to the onset of symptoms. And then we kind of study these individuals over time to try to identify potential markers that could help us identify the disease at earlier stages. This teaches us a lot about ALS disease biology that's applicable also to people with sporadic disease, and potentially offers the opportunity to help prevent development of ALS. Next slide. This is just showing briefly kind of the number of patients who are in. So we're up to almost 500 people who we've kind of done genetic testing in. And have been following. Next slide. And really we do kind of a whole range of assessments, including blood collection, spinal fluid collection, cognitive assessments, neurologic examinations to monitor for signs of disease, and then more preliminary work in doing different forms of electrophysiologic assessments like EMGs and nerve conduction studies, as well as potentially trying to use kind of digital monitoring forms to help try to, again, detect early signs of disease. Next slide. A lot of this has been really exciting so far. So we've seen some markers or biomarkers that we can detect in blood or spinal fluid that could potentially inform someone's risk of disease. The best developed of these is something called neurofilament light chain, which you can kind of see off on the left. It's basically a marker of nerve injury that has been found to be elevated potentially 6 to 12 months before the onset of ALS. And recently, our group was contributing to some work on a biomarker that's kind of a type of, it's called cryptic exon, where it's a marker of loss of TDP-43 dysfunction, which we found in both ALS patients as well as in asymptomatic carriers of the C9orf72 gene. Next slide. And I think all of this is really important. If we can kind of predict when somebody's at most at risk for developing ALS, that would be a really great time to intervene with a medication. And so amongst the kind of considerations that have been ongoing recently, there's an ongoing clinical trial for people who are asymptomatic SOD1 gene carriers who don't yet have ALS. This is called the ATLAS trial, where actually they're trying to kind of look at this neurofilament light chain level over time and basically target people who have rising neurofilament levels and treat them with either tofersen, which is this SOD1 antisense oligonucleotide, or a placebo, with really the goal of seeing, could we prevent somebody from developing ALS? And lastly, I think there's a lot of interesting things that are coming out of this of really how should we try to monitor and counsel people who are at genetic risk of ALS or FTD. There's been thoughts of should we try treating people who don't yet have ALS with riluzole to prevent it? Or are there lifestyle modifications or supplements that we could do? So really that's the kind of end of my presentation. So I think I would love to kind of take some questions. We can go to the next slide.
Thank you so much, Dr. Gray. That was a wonderful presentation. So much information, and we do have a lot of questions coming in. I just want to remind everybody in the audience that we aren't going to be taking questions tonight about the platform trial directly, but you can always reach out to Catherine, and I'm sure if she hasn't, she'll drop her contact information into the chat for you. And if you have questions as we go through this, please feel free to keep putting them into the Q&A. But we'll go ahead and get started. First question for you. Are you aware of any trials going on for C9 genetic carriers?
Yeah, so first of all, I'll just say that, C9 gene, or so when you're saying C9 gene carriers, I just want to make sure that we're talking about people who have ALS currently. So what I would say is for people who have C9orf72 associated ALS, these patients are typically still able to enter into a wide variety of clinical trials for both genetic and sporadic disease. Unfortunately, there aren't any current very C9 targeted medications that are really aiming to hit the exact gene or protein at the moment. The only one that I can think of that's ongoing right now is there's a trial at the University of Florida looking at a diabetes drug called metformin that have been found to show some promise in early animal models. There have been a couple antisense oligonucleotide trials for C9 in recent years that unfortunately didn't show evidence of efficacy. I do think we're likely to see more in the coming years. For the question of maybe for C9 gene carriers, right now there's a couple options. So one is there are a couple of observational trials where people could be followed and kind of closely monitored and contribute to our understanding of ALS. So those would be, say, the DIAL study at Mass General and WashU, the ALS Families Project at Columbia University, and maybe the PREFAL study at the University of Miami. Very soon, we're going to have a new study called the All ALS study, which will be kind of at a national scale with 34 sites that will follow C9 gene carriers. I do know that Synapticure is kind of doing a clinical trial where they're actually offering riluzole to C9 gene carriers who don't yet have disease. And that is something that sometimes people have looked into. But I think the best advice overall would be kind of talk with a neurologist who's knowledgeable about this disease, and they can help provide some guidance.
Yeah, thank you for that. We also had gotten a question from an attendee who is a C9 gene carrier who had, we try to find out all the information that we can and have said, would you consider C9 to be just as untreatable currently as sporadic, or does it actually fall into that genetic category of more treatable ALS?
So I think right now, so C9 is not like SOD1 where there's a specific FDA approved gene therapy. So we're still mostly using the same medications and treatments as for sporadic. I do think, I think there's always a lot of hope to me in kind of treatments for C9 and other genetic forms of ALS. And it's because if we really know the exact target, I think it's easier sometimes to develop medications. We are still seeing a lot of kind of promising kind of early stage work for C9 involving antisense oligonucleotides or gene therapies, but there's nothing currently in clinical trials right now, and we hope that's going to change very soon.
Thank you. Okay, the next question is about TDP43. So the chart of ALS associated gene mutations that you shared with us showed the TDP43. Can you discuss the relationship of TDP43 mutation as a causal mechanism versus the well-known TDP43 aggregation pathology?
Yeah, it's a great question. So basically, so mutations in the TARDP or kind of TDP43 gene are, I believe, the fourth most common genetic cause of ALS. So it's a little less than kind of 1% of the total. So TDP43, it's a normal protein that is within the body. It regulates kind of RNA processing within cells. And what we see in people who have sporadic ALS, as well as almost all genetic forms of ALS, aside from SOD1 and FUS, is that the TDP43 moves from where it's normally expressed in the kind of nucleus of the cells out to the cytoplasm. And it kind of clumps up and aggregates within the cytoplasm. There's a couple features of kind of TDP43. So there's two main mechanisms. So one is the question of how much of problems with TDP43 in sporadic ALS and genetic forms is related to loss of the normal TDP43 function within the nucleus, and how much is related to this aggregation. We typically think of the people who have TARDP mutations as more being kind of a toxic gain of function related to the aggregation, would be kind of my thought. I think we're still learning a little bit more about the people who carry those gene mutations because it's a relatively uncommon genetic mutation. It's not one that we understand quite as well right now as we do, say, SOD1 or C9orf72.
Can you clarify, as I'm listening to you talk and we're talking about, excuse me, genetic and sporadic ALS, on your slide, I think I understood that the first person in a family to receive an ALS diagnosis that a gene is known is a genetic case of ALS, but the second person creates a familial case.
Yeah, so
Correct?
this is where I think this classification system leaves a lot to be desired because it's very confusing. And so kind of the way I actually prefer ideally to do it was I would refer to something as essentially either genetic or non-genetic and get rid of the kind of sporadic nomenclature. Because I've seen people who have SOD1, ALS, who they're the first person in the family we've known about having disease, or same thing in C9, somebody may be the first person that we know about having disease. And that can happen for a whole variety of reasons. So maybe someone's parent who might have been affected by, ALS if they had lived long enough, died very early on, or maybe someone was adopted. And so I think it seems a little silly when we know there's a genetic cause in an individual to classify them as sporadic just because we don't know of any other family members who've been affected.
That makes sense. Thank you for explaining that. Next question, what is the role of NEK1 in ALS pathophysiology? That's a mouthful.
Yeah, it's a great question. So NEK1 is kind of a rarer kind of ALS. Well, it's actually not that uncommon. So ALS or NEK1 is a little bit closer to one of those kind of risk modifiers in my view. So there's a couple different types of mutations in NEK1, but most of them increase the risk of developing ALS by kind of less than a tenfold increase. And so the majority of people who carry NEK1 mutations do not end up developing ALS. And so, when you look at their kind of family histories, it looks a little bit more like sporadic disease. However, it still increases people's risk pretty substantially. So the idea is that, NEK1 might be one of those genes that people would actually target with something like an antisense oligonucleotide. And it may, have benefits even in sporadic disease.
So, question related to that, on your slide where you were talking about the risk factor, and on the right-hand side of that slide where it was less of a risk factor for those genes, and there were multiple different factors that you indicated, how are those factors aligned with each gene? Is it each factor in all genes or each factor in a specific gene?
Oh, I see. I think we don't fully understand.
Okay.
Is the honest. So, there was a kind of paper out of one of the UK groups that talked a little bit about like a kind of 6-factor model of developing ALS, where somebody basically takes multiple risk factors in order to actually develop this disease. And in their model, I think it was the SOD1 gene might count for, say, 4 of those 6 risk factors. And if you had the C9orf72, it was two or three of those, 6 risk factors. And then basically, I think the idea would be you maybe add on, an environmental exposure or the history of concussion or something else that kind of tips someone over the edge. And it's only once they kind of get that final hit that they might end up developing ALS. And so I kind of think about all of these risk factor genes as a small contribution towards that overall risk and hitting that tipping point.
Thank you for that clarification. Have you personally ever seen any patients improving while on Qalsody or regaining function?
Yeah, so I mean, I can say I don't. So I can safely say that I've seen people who've had kind of clear stabilization of disease, and I have a number of colleagues who have treated individuals mostly with kind of more slowly progressive forms of ALS, who have seen kind of improvement in both kind of physical examination as well as on electrodiagnostic studies. And so again, I think it can be a little challenging and it's hard to read too much into some of the anecdotal experience. However, I think it's been very, very promising so far, at least for a subset of people that they really have had stabilization or even some small amount of improvement. And I think the exciting thing to me is if it can be done in one form of ALS, I think that means it can be done in other forms of ALS.
Yeah, that's really helpful. So as we're identifying new genes and the role in ALS, how often should someone living with ALS and a negative genetic screening retest for their sake of their family members?
So, Richard, I think that could a little bit be dictated by someone's individual family history. So I think if someone has a strong family history of ALS and has had, negative genetic testing, that would worry me that somebody might have, a kind of unknown genetic cause where we just haven't discovered the gene yet. I think if say you were somebody who, has not had any family history of ALS, I would generally feel relatively kind of secure that it's relatively unlikely that there would be at least a strong genetic risk factor within the family. With that said, we know that sequencing technologies change, that we discover new genes. I think it's worth revisiting maybe every 3 years or so. And at least asking maybe your neurologist to see, again, have there been any new gene discoveries that we should screen for?
Perfect. So we have an attendee who is a C9 carrier diagnosed with ALS, but nobody had died from ALS other than 2 generations ago. So is it common for C9 to skip generations?
So what I would say is that the gene itself doesn't skip a generation, but this is that getting back to that concept of penetrance that I tried to kind of touch on briefly, which is what is the chance that someone who carries the gene ends up developing disease? And so it turns out there are kind of many family members, even in C9 families of people who carry the gene, and they may live, up to the age of 80 and actually never develop either ALS or FTD. What can happen, and it's maybe even more common than that though, is that someone dies of a heart attack at age 55, and if they lived to 65, they might have developed ALS at that point. And so I think that story of their, someone having C9 and then their grandparent having C9 ALS is we see it relatively frequently. The other thing that I'll say that can happen is sometimes that gene mutation can cause frontotemporal dementia. And sometimes the changes of frontotemporal dementia can be a little bit subtle and can be mistaken for, say, Alzheimer's disease, or can be mistaken for even normal aging.
Perfect. I know we're at the hour. I'm going to finish off a couple of questions really quickly, if that's okay with you. One question: in Alzheimer's CSF, neurofilaments increased 9 years before the disease onset, but the data you presented was 1 year. before. So is that NFL in the CSF or in blood, or does it matter?
So so I think it depends a little bit. So we're still learning about this, I have to say. So that data that was presented is basically based on 15 patients or so. It's almost entirely people who have a specific genetic form of ALS called SOD1A5V, which is a really rapidly progressive form. And so I think it makes sense that it kind of spikes very quickly. There's some data to suggest that in, say, C9 ALS, that it may be a more gradual rise over the course of 2 or 3 years even, and we're still learning more about that. The data that I did show was in peripheral blood, but you actually see a very similar trend in spinal fluid. It just turns out that since peripheral blood is basically as good as CSF, it's much easier to monitor this more frequently from blood rather than going through repeated lumbar punctures.
Yes, yes. Okay, so I'm going to ask you the last question for tonight. It's kind of a word problem, so I'm going to read it and hope it gets correct. If one twin gets ALS and the other does not, have there been any tests about biology, environment, occupational differences to determine what the difference between those two people may be?
So I would have to take a little bit more of a look. I mean, so the idea, I guess, is that both twins would, presuming you're talking about identical twins, have essentially an identical genetic background. So why does one get it, not the other? I think it does come down to that, question of, occupational differences, environmental factors. So I think people have kind of looked at that. We definitely do see that there is a significantly increased risk of ALS in people who have an identical twin, suggesting that the genetics play a big role, but it's definitely not the whole story. So this is that gene environment interaction. And I think we're still, even in genetic forms of ALS like C9, we're trying to learn as well. Are there environmental or occupational effects that affect what age does this disease come on? Does someone develop ALS or FTD? And again, it's still a source of a lot of investigation.
Yeah, there's a lot of pieces.
Yeah.
Okay, so I think that we got through our main questions. Dr. Garret, any last words that you'd like to share?
No. I think this is an area where, I feel very encouraged. I think, we're really looking at an exciting time where, having the first trial that's even aiming to prevent ALS is pretty extraordinary. And I think the approval of tofersen was really exciting, not just for the people who have SOD1 ALS, but I think does give me kind of a lot of hope for the whole community.
Thank you so much. We'll end on that note of hope. Thank you all for joining us, and we will see you next week for the platform trial update. Have a great night.
Thank you so much.